Good evening, everyone. Welcome to this webinar on the role of the 11 to 14-week ultrasound in the era of cell-free DNA screening, presented by Dr. Bryann Bromley. The AIUM is accredited by the ACCME. This webinar is designated for one AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to describe their performance metrics of cell-free DNA for detecting targeted aneuploidies. Participants should also be able to characterize the advantages and disadvantages to screening with cell-free DNA and specify the utility of a prerequisite ultrasound and role of NT measurement. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Dr. Bromley and AIUM staff members involved with this activity have no disclosures. At the conclusion of the webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded one CME credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During tonight's presentation, if you have any questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Dr. Bryann Bromley.
Hello, everybody. Thank you for joining me tonight. I'm going to be speaking to you about the role of the 11 to 14-week ultrasound in the era of cell-free DNA screening. As was mentioned, I have no disclosures to make. Cell-free DNA obtained from maternal blood includes both a maternal and a fetal placental component. What we generally refer to as the fetal component actually originates from the placenta by the process of apoptosis, which is the turnover of the syncytial trophoblast cells. The fetal placental contribution to the cell-free DNA comprises about 10 to 20% of the maternal circulating cell-free DNA. It's detectable as early as 5 weeks gestation. However, the fetal fraction is not high enough until about 10 weeks gestation to be of diagnostic utility. Cell-free DNA is cleared very rapidly after delivery. The half-life is approximately an hour, and by 2 days post-delivery, it is essentially cleared from the maternal circulation. As shown in this chart, cell-free DNA has a very high sensitivity and low false positive rate for the detection of the targeted aneuploidies. They're primarily trisomy 21, to a slightly lesser extent trisomy 18 and trisomy 13. Now, this chart is a pooled weighted detection rate from a recent meta-analysis. It's important to recognize, however, that these metrics do not include a lot of no-call results, fetal mosaicisms, or samples with low fetal fraction. And therefore, they have the potential to overstate the detection rate and minimize the false positive rate, which are intrinsic performance metrics of the test itself. These data that are listed here show the sensitivity and false positive and false negative rates when you actually take into account test failures of both normal and abnormal samples, as well as successful repeat testing after an initial failure. And you can see that the sensitivity is very good for the detection of the major autosomal trisomies, and the false positive rate, most notably, is much lower than what we have characteristically seen with combined first trimester screening. Now, what's important to the clinical provider is the positive and negative predictive values. If you have a positive test, how likely is it that the fetus actually has the disease process? And that's dependent on the prevalence of the aneuploidy within the population. And while there are tables that show ranges, the best way to figure that out for your patient is to use a calculator that's available at perinatalquality.org. So this is an image from that website, and what you can see is that there is an NIPT cell-free DNA predictive value calculator that is free. And what you do is you go on the website and you look for the chromosome condition, you enter the maternal age at delivery, and here I've randomly entered a positive value for trisomy 18 from a cell-free DNA test on a 25-year-old. You can put in your own sensitivity and specificity metrics for the lab that you're in. Sorry, that jumped on me. And then you hit calculate. And if you hit calculate, it'll tell you the probability of the result being a true positive here versus a false positive result, so that you can counsel your patient appropriately. Now, what are the reasons for discordant cell-free DNA results? Certainly, false positives and false negatives do occur. One of the most common reasons for a false positive is something called confined placental mosaicism. And this refers to a situation when the genotype of the placenta is discordant with that of the fetus. Now, the cell-free DNA result in this situation is analytically correct, but not clinically correct, because the placenta and the fetus have a different genotype. We know from work on CVS that this can happen in 1 to 2% of CVS samples, so certainly it is something we see. You may have a false positive because of an early twin demise. Certainly aneuploidy is associated with an increased risk of early pregnancy loss. And so if you have an early pregnancy loss, that circulating cell-free DNA may still be within the maternal compartment. Unexpected maternal mosaicisms or copy number variants can give you an abnormal result. If you get a result that shows multiple high-risk aneuploidies, think of maternal malignancy, because tumors can cause very unusual patterns within cell-free DNA reports. Similarly, if a patient has had a transplant or a recent transfusion from a male, there may be a sex chromosome discordance. False negatives may also occur, again, due to a confined placental mosaicism where there's a discordance between the fetus and the placenta. You may have a false negative because of a low fetal fraction of cell-free DNA where there's not enough material to produce an adequate or reliable result. And similarly, although less likely, some maternal mosaicisms or copy number variants may produce false negative results. About 1 to 8% of samples are non-reportable, and the most common cause of that is a low fetal fraction. We don't tend to report out a result with a fetal fraction of less than 4%. What causes low fetal fraction? Certainly early gestational age, when there's not enough of a fetal fraction within the maternal circulation. Maternal obesity, and that probably is associated with an increased total amount of cell-free DNA due to increased apoptosis from the maternal adipocytes. since the fetal fraction is, or the fetal contribution is the same, if you have a higher maternal contribution, you'll have a lower percentage. There's been recent reports that increased physical activity may result in a lower fetal fraction, and when you have a low fetal fraction, there is an increased risk of aneuploidy. Similarly, assay failures can occur, but this will vary across platforms. Now, the implementation of cell-free DNA screening has been different and quite diverse across the country, but the marketing has been aggressive for this expensive test. And providers have been given the sensitivity and specificity metrics of the test, but they don't always understand the difference between sensitivity and specificity and the positive predictive value. The problem with inadequate provider education is that it can lead to bad press. And this is an example of an article that was published in the Boston Globe a couple of years ago, where a positive result led potentially somebody to consider termination. The other thing that we have noticed is that there's a decrease in referrals to genetic counselors since implementing cell-free DNA screening. And while some of this decrease in referral is appropriate due to the lower false positive rate, there has also been a decrease in referrals of patients who are not really candidates for cell-free DNA screening. Similarly, there's been a decrease in diagnostic testing. And the last thing to consider is, what is the role of the first trimester ultrasound if we can use cell-free DNA screening from maternal blood to have a higher sensitivity and lower false positive rate in screening for the autosomal trisomies? Why do we need to do a nuchal translucency or a combined first trimester screen? What are we adding to the clinical scenario? Well, let's look at the prevalence of chromosomal abnormalities. Chromosomal abnormalities occur in about 44 per 10,000 births. Historically, we have really focused on trisomy 21. And about 53% of chromosomal abnormalities are due to trisomy 21. There's another smaller component of trisomy 18 and 13, and then again an additional contribution of the sex chromosome aneuploidies. Overall, however, that represents about 83% of the chromosomal abnormalities that we see in humans, which leaves us with 17% that are undetectable by current cell-free DNA screening methodologies. Norton and colleagues looked at data from the California prenatal screening program, and they evaluated the chromosomal abnormalities detected by combined first trimester screening versus cell-free DNA. And what they did is they looked at over 1.3 million patients screened and found that 5.2% had a screen positive rate, which is what you would expect. 38% of them, or just under, underwent diagnostic testing, of which 11.5% were abnormal. Now, if they looked at what was detectable and non-detectable by cell-free DNA screening, approximately 83% would have been detectable by current cell-free DNA screening technology. However, standard screening with a positive result followed by invasive testing would have detected an additional 16.9%, which are not currently detectable by cell-free DNA. Of those that are not detectable by cell-free DNA, only about 20% of them had a thickened nuchal translucency. A similar study done in Denmark looked at the potential diagnostic consequences of applying non-invasive prenatal testing, which is another name for cell-free DNA screening, to a population in which the patients of the country were already screened by first trimester combined screening. This was a retrospective population-based study of over 193,000 patients. 5.3% underwent diagnostic testing, of which 10% had an abnormal result. If we look at cell-free DNA applied to that population, 307 of those abnormals would have not been detected by cell-free DNA. And if you look at the pathogenic cell karyotypic abnormalities, about 23% of significant pathogenic karyotypic abnormalities would not have been detected by current cell-free DNA screening. Last year, Norton et al. Looked at cell-free DNA versus sequential screening for the detection of all fetal chromosomal abnormalities. And this was a study in which they looked at just under 500,000 women, of which 2,575 were aneuploid. And what they found was that sequential screening would detect approximately 81%, almost 82% of all karyotypically abnormal fetuses at a false positive rate of 4.5%. If cell-free DNA screening was done and a no-call result, unreportable result, was considered low risk, the detection rate of all aneuploidies was 70.7%, with a false positive rate of 0.7%. If they took the no-call result and considered them high risk, then they were able to detect 77% of aneuploidies, but the false positive rate increased to 3.7%. So while cell-free DNA screening is excellent for the targeted aneuploidies and superior to first trimester screening for trisomy 21, there are many other atypical karyotypes which are missed when we only use targeted cell-free DNA screening. We're all used to doing the 11 to 14 week scan, which was introduced to measure the nuchal translucency, and we're very good at measuring nuchal translucencies. We know how to set up our image, we know how to measure it, we know how to look at the presence of a nasal bone or the absence of a nasal bone. Some of us go further and look at flow in the ductus venosus or tricuspid regurgitation, but we're very familiar with the NT scan. Our experience has shown us, however, that the 11 to 14 week scan is so much more than just measuring the NT or looking at the nasal bone or measuring the crown rump length. It is our first opportunity, or one of the first opportunities, to assign gestational age based on biometry. It allows us to diagnose multiple gestations and characterize amnionicity and chorionicity, which is much more accurate in the first trimester than in the second trimester. Here you can see an example of a monochorionic, monoamniotic twin pair, and you can see there's a single membrane circling the fetuses and one yolk sac. One yolk sac is predictive of this situation 95% of the time. If you have a twin gestation and it's a monochorionic twin gestation, in this case you have the diamniotic, you can see the membrane separating them. If you look at the nuchal translucency, you can see it's discordant between these two fetuses, and this can be a predictor of twin-to-twin transfusion syndrome. We also look at the uterus. We can see fibroids within the uterus, which may impact the pregnancy. We get to look at the adnexa. In this case, we see an adnexal mass, a solid mass off the ovary in an early pregnancy. This is a fibroma, and on occasion we'll pick up a more significant or serious mass, such as this fetus with this ovary with this excrescence with a lot of color flow, which was an endometrioid carcinoma in a 9 weeks gestation. So the NT scan really gives, the 11 to 14 week scan, I should say, gives us a lot of information. Similarly, we've had an opportunity to look at the fetus within this gestational age window, and we've become adept at recognizing major congenital abnormalities. If we look at the fetus in a systematic way, we can examine the cranium. You can see in this fetus there is a single monoventricle. Your thalami are fused, and this fetus has alobar holoprosencephaly. This is an axial scan through the fetal abdomen. We often should be looking at the umbilical cord insertion site, and you can see this irregular mass projecting from the anterior abdominal wall and a right paramedian defect in a fetus with gastroschisis. Or this fetus, where on mid-sagittal view you can see a large liver-containing omphalocele. We can look at the extremities. In this case, this fetus has one normal lower extremity, but has a transverse amputation defect of the other lower extremity. And it is easier actually to look at the extremities in the 11 to 14 week gestational age window than it is at the time of a second trimester anatomic scan, where the fetus can be doing a tricep extension or having its hands hidden behind it. Much easier to see in the 11 to 14 week window. When we look at the mid-sagittal profile, which is one of the landmarks we have to look at in order to measure our nuchal translucency or evaluate our nasal bone, we can look at the contour of the face, and this fetus has micrognathia. Again, if we look at the mid-sagittal view, you can see how abnormal this profile looks. It's flattened. There's an abnormal placement of the nasal bone. The palate is not seen. This fetus had a large facial cleft. So we can do an early anatomic evaluation of the fetus. Now, Rossi et al. Did a recent review in 2013 where they looked at the accuracy of ultrasound between 11 and 14 weeks for the detection of structural anomalies. And the inclusion criteria included a systematic evaluation of the brain, the face, the thorax, the cardiac system, the abdomen, the urinary tract, and the limbs, and they had to have postnatal exam or pathology to be included in this series. But overall, in these 19 studies of 78,000 fetuses, 1%, a little over 1%, were abnormal. And ultrasound in that gestational age window was able to detect 51% of these structural abnormalities. This is an example of a fetus where in the process of doing your early anatomic scan, you can look at the face and what catches your eye. Here you can see one normal eye. Look at this eye. You can never make out the orbit. And if you look in this modified 3D rendered view of the face, you can see this fetus has a large cleft extending up to the orbit, possibly from this structure here, which is an amniotic band. This fetus has a negative cell-free DNA, but has a major abnormality that was able to be detected at 13 weeks gestation. It's another fetus where in a mid-sagittal view you get a very nice nuchal translucency. It's a little bit thickened, it's a little prominent, which should really prompt you to take a good look at the other anatomy. And here you can see in the same fetus an axial scan through the fetal chest, and we're sort of scanning through the chest here, the heart, down to the stomach, and look at this four-chamber view. It's not symmetrical. You're missing the right ventricle. This fetus had a hypoplastic right heart, which you're picking up at approximately 13.5 to 14 weeks gestation. Now, it's important to identify these malformations. The causes of malformations can be chromosomal, but that's only about 10% of the time. If you add in single gene disorders and familial abnormalities, you'll come up to about 27% as an etiology of a malformation. But recognize that 43% of malformations are unknown cause. This is a beautiful slide that was given to me by the Perinatal Quality Foundation as part of their educational material. And what it shows on this x-axis is maternal age from very young to advanced maternal age, and the relative contribution of these various abnormalities. And what you can see is cell-free DNA is going to look for your targeted autosomal trisomies, but they don't really become an important or big significant contribution to the number of abnormalities until women start getting into an older age group. Younger women are much more likely to have structural defects that are non-cardiac, congenital heart defects, and abnormalities in copy numbers, which will not be detectable by cell-free DNA. And so it's important to really take a look at these fetuses in that 11 to 14 week gestational age window to look for anatomic abnormalities. And you can see a 3D rendered image here of a fetus where one leg is normal and there's a very abnormal lower extremity. Now, let's look at the utility of a prerequisite ultrasound at 10 to 14 weeks in the era of cell-free DNA screening. And this is a lovely study by Dr. Bora, which was published this year in Ultrasound, Obstetrics, and Gynecology. And this was a retrospective cohort study of 2,337 women of advanced maternal age, excuse me, and encompassed 2462 fetuses. And what this investigator was looking at were unexpected findings at the time of the ultrasound. What they found was that 16% of cases of patients had an ultrasound finding that would alter counseling about screening or testing results. And we'll go over each of these individually. The first thing is 6.5% of fetuses were non-viable, and you can recognize the sort of ground glass gray appearance that you see when a fetus is not alive. If you have the opportunity to put on 3D, you can sometimes pick up some structural abnormalities. In this case, you can see this fetus had a very abnormal face. This may be helpful in explaining the question why that many parents will have and offer some consolation. Or this fetus. This fetus also had no fetal cardiac activity. But what else can you see in the image that would help you sort of figure out why this fetus may have succumbed in utero? Look at the placenta. There's a fixed cystic placenta here. And this is a fetus with a partial molar pregnancy or triploidy. In this study, 5.4% of the pregnancies required revision and dating. And this may be just simply that the patient's menstrual cycle is off, but you really want to wait till 10 weeks gestation before you send off your cell-free DNA test, because otherwise the fetal fraction may be too low. But on occasion, you may see other types of things by looking carefully at the fetus. This fetus should have been about 11 and a half weeks gestation and came in for a nuchal translucency scan. And while I admit this is not the proper technique, we had already figured out that the fetus was, quote, too young for this test. But look at this fetus. Does anything catch your eye when you look at this? What do you think? Can you see that the head is very big for the body? This fetus has the same condition, and it's triploidy. It's a digynic triploidy, where the fetus has asymmetric growth restriction with a big head and a small body. And in those situations, you may be tempted to redate the pregnancy when in fact the fetus is abnormal and really should be referred for diagnostic testing, not rescheduled for a follow-up exam in 2 weeks. What about this baby? This baby should have been 12 and a half weeks gestation, came in, you do your crown rump length, it's 11 weeks, 6 days, which we can do an NT on this. Certainly we do them between 45 and 84 millimeters. What catches your eye? Take a good look. The profile is a little unusual, but what about the head? You don't see a cranium. If you went on to do a transvaginal scan, you can see that there is no cranium. There's some residual brain development here. Maybe this is the thalami, hard to tell. But you can see that the brain is floating loosely within the amniotic cavity. And in 3D, you can see there's no cranium, and you can see the brain just amorphously within the amniotic fluid. In this study by Vora, 1.4% of patients had a multiple gestation, and aside from assigning amnionicity and chorionicity, patients with a multiple gestation and twins may elect for standard screening, as cell-free DNA screening is not currently supported by ACOG in the setting of a multiple gestation. At minimum, it would be important to change your counseling concerning the test performance metrics of cell-free DNA, because twins have a higher test failure rate and a lower aneuploidy detection rate. In this particular case, you have a set of twins, and one twin is completely normal looking, but look at the other one. The other one is cystic and amorphous in its configuration and has reversed arterial flow. This is a fetus with reversed arterial perfusion, or a trap twin, or an acardiac twin. And what about this fetus? This fetus had a negative cell-free DNA, but if you scan through the head, you can see that it's conjoined, and the intracranial anatomy is abnormal because it has 4 different sets of choroid plexes. Cell-free DNA screening in this situation is not really going to be particularly contributory. It's important also to recognize that you may have a demise of a co-twin. In this case, you have one normal twin that was here and one early demise. This can give us a false positive for aneuploidy, and also can give us incorrect sex determination on cell-free DNA screening. So it may not be the best test to offer to this patient. Fetal anomalies occur in approximately 2.9% of cases. And if you see a structural abnormality, the patient needs to be counseled about the option of diagnostic testing with microarray. Microarray identifies 6.5% pathogenic conditions in patients with anomalies in normal karyotype, and higher even for some conditions. This is an axial scan through the fetal chest. You can see that the heart is pushed way over in the chest by the stomach, and this is a congenital diaphragmatic hernia, where the microarray abnormalities may even approach as high as 20%. Or this fetus, where you can see has an encephalocele just protruding. This is a case that was shared with me by my friend Dr. Luis Izquierdo, and it's a case where you have heterotaxy. You have an abnormal looking heart and the stomach on the other side. And while this condition is not classically associated with standard karyotypic abnormalities, there are laterality gene disorders which may be there and should be diagnosed, and up to 20% will have a significant copy number variant. So again, cell-free DNA would not be prudent in this situation. This is a fetus who came in, again, negative cell-free DNA type of screening. You would not expect aneuploidy. And what do you see when you look at the lower end of this fetus? You see this big mass extending off the lower spine. And if you put color on, you can see it has highly vascular. And this is an example of a sacrococcygeal teratoma in a young fetus. By making this diagnosis early, you give the parents the option of finding out everything about the situation, having expert consultation, and making a decision about how they wish to proceed. If we look at the role of cell-free DNA in fetuses with ultrasound anomalies, we can look at a study by Bonacci et al. In 2015 where they looked at 773 fetuses that were at risk for abnormality who had negative cell-free DNA and an available karyotype. And what they found, their primary outcome was looking at pathogenic karyotype other than the standard major autosomal trisomies. If they looked at those with a normal ultrasound, 2 out of 483, or 0.4%, had an abnormal karyotype that would not have been picked up. If you had an abnormal ultrasound, which included in this study those with an NT of 3.5 millimeters or greater, 23 out of 290 had an abnormal karyotype, or 7.9%. While many of these, or 56%, were sex chromosome aneuploidy, that is still a significant, falsely reassuring result. If you then add in this study the 3 patients who had a false negative for trisomy 18, 9% would have been missed. And so cell-free DNA is falsely reassuring in the setting of an abnormal ultrasound. In some cases, the anomaly that you see may be so devastating that the patient may elect not to continue with diagnostic testing or any type of screening. In this case, you can see an axial scan through the fetal body, and you can see an ectopia cordis here beating outside the chest, or this 3D rendered image of a fetus with Anencephaly, or this fetus with a large bladder outlet obstruction. Now, in the study of Vora et al., 155, or 6.6% of the study participants had a first trimester ultrasound at less than 10 weeks gestation. And 22% of these had an unexpected finding at the 10 to 14 week scan. Excuse me, which tells us that a very early scan still can't replace the 10 to 14 week gestational age window. Another study, which was done by Emily Reif in our hospital, looked at what the role of the 11 to 14 week ultrasound was in women with negative cell-free DNA screening. And this was a retrospective cohort study of 1,739 patients who were screened with cell-free DNA screening based on advanced maternal age or a history of trisomy. All of them had an 11 to 14 week ultrasound, and the primary outcome in this study was an unexpected finding at the time of the 11 to 14 week scan. They found overall that 3.5% of patients in the study had an unexpected finding. 0.6% had an intrauterine demise, and there were unexpected multiples in 0.7%, including a case like this one where the patient had had a 7-week scan, which had shown a singleton, had a negative cell-free DNA, and was sent in for an early, first trimester anatomic scan at about 13.5 weeks. And here you can see a case of conjoined twins, the 2 heads. Fetal findings were identified in 2.1%. They included fetuses with an isolated thickened NT, which we define in our institution as 3 millimeters or greater. They also included a group of fetuses that had cystic hygromas. Here you can see a cystic hygroma with body thickening along the anterior abdominal wall, with or without structural abnormalities. This fetus happens to have a bowel containing omphalocele as well. They also found a certain number, 11% of the total, of fetuses that had structural abnormalities, but a normal or non-measurable nuchal translucency. So this is an example of one of the fetuses that had a negative cell-free DNA at 10 weeks and came in for their early anatomic scan at 12 weeks. And it's clear that there is a large septated cystic hygroma. You can see the bilateral nuchal hygromas. There's total body lymphedema. You can see the skin thickening and a pleural effusion. If you go down to the lower abdomen, there's a bowel containing omphalocele. And if you look at the extremities, you can see this fetus has a radial ray defect. If you put that all together with what you know about anatomic imaging for trisomies in the second trimester, this would lead you to suspect that this fetus has trisomy 18. The patient elected to terminate the pregnancy without prenatal confirmation because of the sonographic findings, and on termination, the products of conception confirmed the diagnosis of trisomy 18. This is another fetus who came in who had had cell-free DNA at 10 weeks gestation, came in at 12 weeks. And you can see by looking at the axial scan of the fetal head that the orbits are in close proximity to each other. There's hypotelorism. As you go up the head, you can see the fused thalami and a monoventricle and a proboscis. This patient went on to have diagnostic testing, had a normal microarray, normal holoprosencephaly panel, but still had a major abnormality. And this is another fetus who had had a negative cell-free DNA, again, before coming in for her first trimester anatomic scan. And when you look at the fetus, you're measuring the crown rump length. You can see this abnormal occipital protrusion. And on axial scan, you can see the defect in the cranium, the protrusion of the brain tissue and surrounding edema. And this is a fetus with an encephalocele. If you throw on your 3D, you confirm your encephalocele. But look here, there's another little neural tube defect. And again, this fetus had a normal karyotype on diagnostic testing and actually had an intrauterine fetal demise. Now, this study probably underestimates the role of the 11 to 14 week scan because during the study, timing of the cell-free DNA was at the discretion of the OB. And certainly if a patient comes in for their 11 to 14 week scan and you notice a large septated cystic hygroma and total body lymphedema, that patient may elect against having cell-free DNA screening and may change and go to diagnostic testing. Or you may have a patient like this one where all you do is measure the crown rump. You can see that the cranium is not developed properly. This patient may go directly to termination of pregnancy without having any genetic analysis. So what is the role of the nuchal translucency measurement in this era of cell-free DNA screening? Well, the first question is, what really is a thick NT? And a thickened nuchal translucency is defined in many different ways. Certainly it can be defined as greater than the 95th percentile, greater than the 99th percentile, an NT of 3 millimeters or bigger, 3.5 millimeters, and so forth. So the studies are quite variable in that regard. What we do know, however, is that a thick NT is associated with an increased risk of karyotypic abnormalities, structural anomalies, and other genetic conditions. Suka et al. Reported an abundance of genetic and atypical chromosomal syndromes associated with the thickened nuchal translucency, most notably the 22q11 deletion or duplication, Noonan Syndrome, and many other genetic syndromes, including Smith-Lemli-Opitz, spinal muscular atrophy, congenital adrenal hyperplasia, and so on and so forth. We know that an increased nuchal translucency can be associated with chromosomal microarray abnormalities. As you know, chromosomal microarray detects copy number variants within the genome that are not identifiable by standard karyotype. And early reports looking at the value of microarray fetuses with an increased NT gave contradictory results. However, in this recent meta-analysis by Grandi et al., it was demonstrated that the chromosomal microanalysis added additional information in 5% of fetuses with a thickened NT and a normal karyotype. If the thick NT was not isolated, the there was a 7% increased detection rate of abnormalities using microarray, and if it was isolated, about 4%. So certainly chromosomal microarray can add additional information. Now, the most commonly detected abnormality when you do a chromosomal microarray in the setting of a thickened nuchal translucency is a 22q11 deletion, or de Jour syndrome. This usually is associated with cardiac abnormalities. In this case, you can see an axial scan through the fetal chest with an abnormal heart in a fetus with a de Jour syndrome. Other abnormalities can be detected generally in the second trimester. In fetuses with a normal karyotype, there's an increased risk of Noonan syndrome. And Noonan syndrome is a frequent genetic syndrome that's associated with increased nuchal translucency. It is an autosomal dominant finding that is generally characterized by unusual facies, short stature, congenital heart defects, and so forth. Interestingly enough, however, 2 to 10% of fetuses with an NT over 3 millimeters will have Noonan syndrome, and 10% of those with a cystic hygroma will have Noonan syndrome. And this requires diagnosis by a gene panel, which is different and not picked up by your microarray. So patients with a thickened nuchal translucency can be at least counseled about considering genetic testing for Noonan syndrome. This is a fetus with Noonan syndrome. In addition to the thickened nuchal translucency, when you look on an axial scan, you can see these septated cystic areas in the back of the neck and jugular lymphatic sacs. There is some debate about whether to screen or not to screen for Noonan syndrome, and many investigators will say that it's probably reasonable to screen for it if you have something in addition to the nuchal translucency, like a thickened nuchal fold in the second trimester, or hydrops, pleural effusion, polyhydramnios, and so forth. This is for 11 to 14 week fetus with Noonan syndrome, and you can see the body lymphedema and the pleural effusion. So another group looked at the question of whether an NT measurement has added value in the setting of NIPT, or cell-free DNA screening. This was a paper by Lichtenbelt and colleagues in Prenatal Diagnosis in 2015. And this was a study, a retrospective cohort study of 221 fetuses with an NT of 3.5 millimeters or greater and karyotypic results available. And of this group, 103 had an abnormal karyotype, of which almost 80% were for your standard autosomal trisomies. And 24 were for atypical karyotypic abnormalities, which would not have been detected by cell-free DNA screening. And what they found of these 24 with these other abnormal karyotypes, 11 had an intrauterine fetal demise. 10 of them had second trimester structural abnormalities, which would allow them to be detected in utero in the second trimester. And only 3 of the entire group had a normal second trimester anatomic scan. These 3, one had triple X and 2 had deletions. So overall, the number of fetuses with an abnormal karyotype in the setting of nuchal translucency was very small, and they did not feel that it was much added benefit. Norton et al. Looked at the utility of the nuchal translucency in identifying chromosomal abnormalities that were not detectable by cell-free DNA. And this was the California screening program again. They had over 1.3 million patients screened. 452,901 had first trimester screening that included an NT, or nuchal translucency measurement. 26,000 of these had a karyotype available. 2572 had an abnormal karyotype, and if you applied which could be detectable by cell-free DNA, just under 75% would have been detectable by cell-free DNA. However, 25% would have been missed by cell-free DNA. This chart shows the distribution of NT measurements using several different definitions with respect to karyotypic abnormalities. And we're just going to focus on an NT measurement of 3 millimeters or greater. This was seen in 1.1% overall of the population. Fetuses with any chromosomal abnormality are designated in pink here, and 40% of those had an NT of 3 millimeters or greater. It was most commonly an autosomal trisomy, and you can see that 48% of those with autosomal trisomy had a nuchal translucency of 3 millimeters or greater. However, 16.6% of those with atypical aneuploidies had a thickened nuchal translucency. So if we added an NT of 3 millimeters or greater to our detection algorithm, we would have increased our detection rate from 75% to 79%. Now, one of the things that this study did not consider is triploidy was not considered to be detectable by cell-free DNA in this study because in many of the platforms used, it is not something that's identifiable. And these fetuses often will have an NT that's normal. This is an example of a fetus with triploidy, and you can see, at least subjectively, this nuchal translucency is not particularly thickened. But if you did an anatomic evaluation of this fetus, you would have noticed that there were several defects. Most notably, there was a discrepancy between the size of the head and the size of the body. And this sort of characteristic asymmetric growth restriction is one of the features that we see in fetuses with triploidy. So we would have likely picked that up by our anatomic imaging. Khalil and al. Looked at the estimation of detection rates of aneuploidy and high-risk pregnancy using an approach based on, again, nuchal translucency measurement and cell-free DNA screening. And this was a cohort study. There were over 5,000 fetuses who had CBS, of which a little over 1,000 had some kind of karyotypic abnormality. These investigators divided up in what type of screening program you're going to use. If you performed a CBS on all of these, you would have a detection rate of 100%, a residual risk of 0%, and you would have had a CBS in all the fetuses. If you had screened this same population with just cell-free DNA screening, you'd pick up 897 of the abnormalities, which is a detection rate of just under 89%, leaving you with a residual risk of aneuploidy of 2.5%, and you would have not performed any CBSs. If, however, you took an intermediary sort of approach where you did a cell-free DNA screen on everybody and you did a CBS on those with a nuchal translucency measurement of 3 millimeters or greater, you would have picked up 957 of the abnormal cases, which is just under 95%, with a residual risk of less than 1%, while doing CBS in about approximately 21% of patients. You can increase your detection rate even greater by including anomalies, and that would have increased your detection rate of pathologic abnormalities to just under 96%. Now, in this study, they considered that cell-free DNA was able to detect sex chromosome aneuploidies and was also able to detect triploidy and tetraploidy based on the SNP platform. And in their calculations, they did not included a 0% failure rate in their analysis. If we look at CVS in the era of cell-free DNA screening, this can also give us some information. This study was to quantify the impact of cell-free DNA screening on CVS between 2008 and 2015, but it also provides some important information on cell-free DNA screening and the 11 to 14 week scan. This study assumed a perfect test performance for cell-free DNA. And what they found in this retrospective cohort study of singletons, there were a little over 2,000 CVSs, of which 342 had an abnormal result, 300 of which were considered pathogenic. And then they looked at the karyotypic abnormalities and divided them into those that were detectable and those that were considered non-detectable by our current cell-free DNA screening platforms. Overall, 58 or 17% of the overall abnormalities were considered not to be detectable by cell-free DNA screening. However, only 16 of these were pathogenic, which represents 5.3% of the pathogenic karyotypes. Well, if they looked at that a little bit more carefully, what they looked at were the indication for those pathogenic abnormalities that were not currently detectable by cell-free DNA. And 5 of the 16 had an NT of less than 3.5 millimeters and no anomalies. Now, that only represents 1.7% of the pathogenic abnormalities. If we look carefully at those 5, 4 out of the 5 were offered or had cell-free DNA screening in a situation they shouldn't have had it. They had heritable conditions. They should not be screened with cell-free DNA. Only 1 of the group had cell-free DNA screening based on advanced maternal age and was truly non-detectable by that type of a screening protocol. And so these authors concluded that the residual risk of an abnormal karyotype is low if cell-free DNA screening is offered in the absence of a structural anomaly, absence of a thick NT, or absence of a relevant family history. So then the next question is, if we have an early ultrasound and we find an abnormality, can we reduce the gestational age at abortion for those with fetal anomalies? And this was a study by Chasen and colleagues, and they looked at 132 fetuses with anomalies, 118 of whom had had an ultrasound at less than 14 weeks gestation. And what they found is that if you had an ultrasound at less than 14 weeks gestation and you had a definitive abnormality, you had a lobar holoprosencephaly, or you had a big omphalocele, and you could say this is a definite abnormality, the average gestational age at termination was 13 weeks. If you suspected an abnormality but were not positive and asked them to come back for an early second trimester anatomic scan, gestational age at termination was on average 17 weeks. If, however, an anomaly was not detected, then the gestational age at termination was much later. But those with an early scan at less than 14 weeks, 35% were able to terminate a pregnancy with an anomaly at 16 weeks gestation or less. If you only had a second trimester scan, the average gestational age at termination was 21 weeks. So the 11 to 14 week scan is critical, and it's critical for a variety of reasons. It's critical to appropriately utilize cell-free DNA screening. If you have an early demise, if you have a twin pregnancy, if you have an anomaly, and so forth, you need to at least discuss why you're doing cell-free DNA screening and recommend potentially consideration of diagnostic testing. The NT and crown rump length, however, are not enough if we're doing the 11 to 14 week scan. We need to do an early fetal anatomic survey, which will allow us to detect 50% of abnormalities. If we do see an increased nuchal translucency, that's most commonly associated with our autosomal trisomies and sex chromosome aneuploidies, which will often be detected or mostly be detected by cell-free DNA screening. However, it would be prudent to refer the patient to genetic counseling because chromosomal microarray will pick up another 5% of abnormalities, and maybe DNA testing for Noonan Syndrome would be at least should be considered. And who knows in the future whether whole exome sequencing will be appropriate or not. That's still an area of investigation. Certainly we know that an increased nuchal translucency is associated with a higher risk of structural abnormalities. And in those cases, we may also recommend diagnostic testing with chromosomal microarray. This fetus here was sent in, had cell-free DNA screening, which was normal. You can see that it has some micronappia, a little bit of a prominent nuchal translucency, but has scoliosis in hemivertebra. This fetus ultimately was demonstrated to have a microarray abnormality, which would not have been picked up on cell-free DNA screening, which it wasn't, or standard karyotype. So why is the first trimester anatomic scan so important? It provides us the earliest opportunity to detect abnormalities which are major in nature and may not be compatible with life. This is a fetus in the later first trimester where you can see that the lower limbs are fused together. This is a fetus with serenomelia. This in general allows the patient the opportunity for diagnostic testing and specialist consultation. It allows the family the opportunity to familiarize themselves with the condition that is present and the support services available. And if they opt to terminate the pregnancy, an earlier diagnosis allows safer termination, more access to facilities which can terminate a pregnancy, and less expensive procedures. There are some limitations, however, to early anatomic scanning. Some findings have an unknown natural history. Certainly some of the cardiac abnormalities may change during the course of gestation. One of the problems that we see is patients acting on findings before confirmation. And it's important to recognize that the first trimester scan, while it identifies 50% of anatomic abnormalities, does not replace the second trimester scan. And so we have to consider cost of the scanning as well as allocation of our resources. What we know is that we do pick up close to 50% of abnormalities in the first trimester. However, there's another significant component picked up in the second trimester to overall give us a prenatal detection rate approaching 90%. So I hope that this talk has been helpful to you, that you have an understanding or a new understanding of the utility of the 11 to 14 week ultrasound in the era of cell-free DNA. And I encourage you to do an anatomic evaluation of your fetuses. If we lose the opportunity to do this, we'll be throwing ourselves back 15, 20 years where we made the diagnosis of anencephaly and limb body wall defects in the second trimester. And that's really, in my opinion, not optimal care for women. Thank you.
Dr. Bromley, there's a few questions for you.
Oh, phew, I thought that I had lost you.
No, we're here.
Oh. Wait, oh my goodness. Okay, sorry. So, is there a BMI cutoff beyond we should not offer DNA testing? We offer it to everybody. Certainly there's data to suggest that with increasing BMI, there's a lower fetal fraction and you get more no-call results. I think it's 180 pounds, but I don't remember off the top of my head, but we offer it to everybody. What is your criteria for a thickened nuchal translucency measurement? That's a very difficult question because it seems to be institution dependent. In our institutions, we use a nuchal translucency of 3 millimeters or greater, and that was probably as a result of work done many years ago where the added benefit of analytes with a nuchal translucency above 3 millimeters was quite low. Certainly a lot of the increased risk of structural abnormalities is based on a nuchal translucency of 3.5 millimeters. You just have to decide, you know, it's always a trade-off between sensitivity and specificity, but in our institution we use 3 millimeters. There's a question here that says, in light of technically difficult exams due to maternal obesity and fetal position, how much effort should be put into getting the standard NT measurement when 11 to 14 week scan is done, evaluating early anatomy as you have described? If you are doing cell-free DNA screening, you should have a sort of subjective evaluation of the nuchal translucency. I don't think that the same degree of precision that you use when you're using it in conjunction with serum analytes is necessary. It probably doesn't matter if your NT is 1.4 millimeters or 1.8 millimeters or 2.4 millimeters, but it does make a difference, as you saw, if you're above 3 millimeters or 3.5 millimeters. So I think you don't have to do the same degree of precision as you do with first trimester combined screening, but you at least want to have an idea of whether it is thickened by whatever criteria you happen to use. We use 3 millimeters. I think that's all I see here. I hope everybody had a good evening.
Thank you very much, Dr. Bromley. And on behalf of the AIUM, our thanks to all of you who participated in tonight's webinar. Please remember to complete the post-test and the activity evaluation. We hope you enjoyed this presentation and will join us again for future webinars. Good night, everyone.